Afternoon. What I consider doing with a non or a delayed union of a femur. So I'll just run through a few cases. So this lady was in her 50s. She'd injured a femur skiing in France. That was her second nail, the picture that you have on your left, because she'd been re-nailed once in France. Then she came back with a bit of pain, and a couple of weeks later, while we were wondering what we were going to do, it broke. So she had, as you can see, a failed implant. So fixed it in the customary way to deal with the complicated proximal femoral non-uniting femur, put a blade plate on, squeezed it with a compression device, and waited for it to heal. It was also bone grafted at that time, and waited for it to heal, and waited for it to heal. And as you can see, there's what looks like a fracture line still declaring itself just by the lesser trochanter, and waited for it to heal, and a CT confirmed that it hadn't healed. So she'd had 3 operations on that, and she was about 3 years out, and she was not uniting. Host factors were fine, she was well. This young lady, she was in her 20s. She'd had a road traffic accident. She had that diaphyseal femoral fracture, and it was nailed, and it was nailed fairly acceptably. At about 6 months, she had the appearance that there was on the X-ray on the right, which you can see appears to show a fracture gap, and there is a locking screw still at the top, and so that locking bolt was removed to allow it to dynamize. And it was watched to see what was happening. And some while later, she was about 9 months post-injury then, she still had a painful femur, and a CT scan showed that there was still a line across it. This chap is in the services, and he had quite a high energy ipsilateral tibia and femoral shaft fracture. As you can see, he had a retrograde nail to his femur, and I saw him in the clinic. He was just coming up for his first anniversary of his injury, and he'd got a painful leg, and he'd been sent up, and he'd come back with a note to say that if he was ununited, that we should consider bringing him into bone grafting. So we've got these 3 cases that have all got slow to unite femora. So what did I do? The first one, took to theatre and through a couple of stab incisions, placed 2 screws across the fracture line. Didn't do anything else, didn't jolly up the fracture with an osteotome or anything, just put screws across there and across the fracture plane. And it joined. The second one, it's difficult to get screws directly across the plane of a transverse fracture, but they're two at 90 degrees to each other across the fracture plane, and they were put in, and the second X-ray there was taken about 10 weeks later, and it's joined. The third one, put screws in across the fracture plane, and it joined. None of them did I open the fracture up, none of them did I do anything else to at all, apart from add stability to it. So the screw was placed across the fracture plane. When I started to do it originally, I thought it was probably important to lag it, as you would. So lagging is an important thing to do. But I think that don't believe that has any real impacts on it. What you're trying to do is just stop the shearing force across the fracture plane. And if you don't lag it, you get more threads holding it. And it's actually a very good bite you get. The other thing that I do is if I'm trying to reduce the strain at the fracture site, then it seems sensible to reduce the load that the patient puts on it, so I'll ask them to restrict that load for 4 to 6 weeks. So that PSRS, percutaneous strain reduction screw, I think is useful thing to think about if you've got a delayed or non-union when there is no need to correct deformity. And the advantage that I see of it is that if you come into the clinic and you present as one of those patients did, I can say we can do this as a day case this week. And if in 8 weeks' time or so there's no progress, we can go on and do a bigger procedure. I just haven't been exchange nailing or bone grafting people since that time. If I haven't needed to change the overall construct, this is all I've done. And it does have a background to it. So there's the strain theory of Perrin that you're all familiar with. But the other thing that comes up, which was coming from Oxford, was quite interesting, is John Kenwright's work, where we all know that you need motion to get callus. And his papers that said that you need 10 cycles a day for 5 weeks to get callus formation. If you don't have those cycles, you won't get anything. Motion is vital. But if you read what's at the bottom of his paper and what's in there, it says that after the cyclical movement, blah, 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 and at the bottom it says the rigidity of the fixation should be increased in the subsequent weeks until the fracture is healed. You need more stability, less strain once the fracture has started to heal. And I think you can tip that balance sometimes with a simple technique of just putting a couple of simple screws in percutaneously. Thank you.